to be with you today. Very happy to be with you today, talking about COVID in MPN. I think maybe you remind what I presented 2 years ago when we started to do this study. I want to summarize all the studies we have done so far in MPN with COVID disease. You know, this study was launched by the European Leukemia Net in March 2020. March 2020 corresponds to the early onset of the pandemic. And as you know, 2 centers were the epicenter of the pandemic. One was here in Bergamo, in Italy, northern Italy, and the second was in Segovia, in Spain. The reason why I started that, because I was impressed very, very much what was happening here in the city during those days. Myself and my wife, my daughter, we had COVID. And at that time, nobody knew what was the COVID, because the only thing we knew is that the mortality was particularly elevated. So, since I am the responsible for the European Leukemia Net on MPN diseases, I conceived to do a study in Europe by asking centers such as centers from Italy, Spain, Germany, France, Croatia, Poland, UK, to join us to do a study. And the study started to recruit a patient from February 2020 to June 21. I want you to consider that I am going to present all the studies we did during this period of time. But we have also other data on patients collected, diagnosed after June 21, after June until now, so that, as you remember, the problem of the vaccination corresponds to this period, so that we are still analyzing what is going on in this series of patients in terms of vaccination. But I have some data to show you also for vaccination and for Omicron or Delta pandemic virus. So let's start with the first part of this. Corresponding to the first wave, we have to distinguish all the epidemiology, all the clinical data that we and others collected during the first wave from February 20 to December 20. This is different from the epidemiology and the clinical problems that were registered after, I mean, in the first wave versus the subsequent waves. I will present you today the comparison between the first and subsequent waves. This is very interesting to know for you. So in the first wave, we registered 175 patients. During this period, February to June 20. And then we followed up these patients for further 6 months. Of course, for surviving patients, of the acute phase. After the acute phase, we have 125 patients survived, and we described also what happened here. We published this. You can read it in the papers. So we published in leukemia in 21. We published in Blood Cancer Journal concerning thrombosis and concerning also the follow-up of this patient. What happened after you have been discharged from the hospital. And then we have 300 further patients with MPN who suffered during the second wave and subsequent waves, starting from June 2020 to June 21. This is very important because you can compare what happened at the beginning and what happened after the first wave. And this is interesting to know because you had to know that in the first wave, there was a concentration of the COVID patients. You see, in 2 months, the great majority of patients were registered. And in these 2 months, a lot of deaths were registered. Maybe you can see in red these columns that corresponds to the mortality rate. Subsequent, during summer, there was a stop, say, of contagiousness, and the patients were not registered because there was a decrease of the intensity of the pandemic. But as in October 2020, after a rest of some months, the disease reappeared, as you see here, a second wave and subsequent waves until May 21. There was a difference, very important difference, not only in terms of the number of patients, but also in terms of concentration of the mortality. This was particularly elevated in 2 months. In this case, subsequently, mortality was diluted over time in a year. So different epidemiology. Why that? Why that? One of the reasons is because there was an evolution of the virus, diagnosed from June to June 21, 2020 to June 21. You know that the original Wuhan virus appeared in January 2020. Later, 5 variants appeared. The first variant was called Alpha variant in UK, and then Beta in South Africa, Gamma in Brazil, and at the end, in December 2020, during the first year of the pandemic, vaccination started. This is very important to know because there is a difference of the epidemiology, different of clinical presentation in patients with PV, ET, and myelofibrosis. And also the evolution of this disease was very different according to these periods of time. WHO, the World Organization of Health, called this variant variants of concern. Concern of what? Concern of infectivity, clinical severity, and to escape the capacity of a vaccination. This is very important, so that there are many variants during the pandemic of the virus, of the original virus, but only variants of concern should be taken into account to judge the severity of this infection. So, what questions have we addressed during this period? So, we have many questions for that. The first question, what is the mortality during the acute phase in the first wave? Is important because we want to know whether this mortality can change over time, because for many reasons, we will see later. So we have data on the risk of thrombosis, clinical sequelae in survivors patients with the PV, ET, and myelofibrosis. We have outcomes in the second versus the first, and we published all this data. What is going on, still unpublished results, refer to Delta and the Omicron variants. All these are variants of concern, as I said. And whether drugs used for MPN, can these drugs affect the effectiveness of a vaccination? This is very important to know. So let's start from this first part of my talk. So what happened during the first wave? What happened in this period was, as I said, we have some patients, 175 patients, and the survivors were 125. 50 of these patients, unfortunately, died during the acute phase. That was very much concentrated in 2 months. These were ET, PV, MF, pre-PMF. Median age was here, but there was also a population less than 60, 50 years, 58, 60. In the pre-fibrotic, we have only older patients. So the population age is between 60 and 80 years, 60, 80 years. You should remember this. During the first wave, the affected MPN referred to an older population. These were followed in the great majority in hospital. They were hospitalized because of the severity of the disease. Only 20% stay at home, and they were outpatients, followed up by the doctors at home. They had also comorbidity, and these are the main comorbidities: hypertension, arterial hypertension, and diabetes mellitus. This was the mortality probability. If you take 100 patients here who entered in hospital, in the first 15 days, 20% died in the first days of hospitalization. And then the curve slowly tended to be to a plateau. It means that if you overcome 30 days after hospitalization, the rate of mortality is negligible. So this is the most period of concern. And where and which were these patients? ET, 25, PV, 19, MF, 48%, incredible. Around 50% of these patients, median age 70, half of this died during these 30 days after hospitalization. And what were the causes of death? Mainly pneumonia, but also multi-organ failure. It means that all the organs were damaged by the virus entry in the body, causing insufficiency of renal insufficiency, hepatic, and other insufficiency. If you compare this mortality, what was registered in that period in non-MPN population, similar age, you can see whether this mortality is higher than what is expected, was expected at the time in a similar age population. And you see, in a similar age population, in patients non-ICU, not intensive care unit, admitted in the hospital, 11% died. But in our case, in our cohort, European Leukemia Net cohort, 28% of deaths were registered. And the comparison of the two indicates that if the question was, are MPN patients at higher risk of death than their counterparts, non-MPN patients, this study was done in Germany. And they said, yes, unfortunately, the case fatalities were 2.5-fold higher than in the cohort and 3.5 higher whether you consider only myelofibrosis. So 2-3-fold higher than normal population. So a problem, a relevant problem for patients with MPN. Similar age, 3 times higher than the normal population. Why that? This was the question. We try to do what we call in statistics, we called multivariate analysis. Multivariate analysis is a term that indicates that you have to consider all the variables that can be that can influence the mortality. For instance, you can consider not only age of the patient, but also the gender. Male, they died 2.4 more times than female. And this is significant. In red is significant. Chronic heart disease is significant. Intensive care unit, but what was very significant and specific for MPN was the ruxolitinib discontinuation. In fact, you see here this curve of mortality. Patients died, as I said, in the first month. This is the curve of the mortality, 100%, 75%. But if you continue with ruxolitinib, you have the same rate of mortality. Survival is exactly the same as those without ruxolitinib. But if you don't continue and you discontinue ruxolitinib, the mortality is very, very high. And you see here, this is highly significant, so that we alert the scientific community of that. And the American Society of Hematology introduced this data on the guidelines of treatment. Please should not stop ruxolitinib, at least absolutely necessary. And this modified everything in terms of mortality, as you will see later. So this was very important. Another point that is in favor of continuation of ruxolitinib is that this experiment. You have to know what happens if you, outside MPN, in the general population, for instance, in the hospital where people median age 80 are admitted, because these institutes for elderly, very elderly people, in this case, these people had a great percentage of comorbidity, hypertension, diabetes, renal insufficiency, heart attacks, and so on. If you give, as this experiment, in this population, ruxolitinib for 13 days, 20 milligrams a day, the overall mortality is 6%. 94% of these people are alive, were alive at 28 days after hospitalization. So this is a proof. The contrary, in the general population, taking ruxolitinib, things are getting better. Why that? And the reason is because ruxolitinib is an anti-inflammatory drug. You reduce the cytokines, you reduce the inflammation, so that the disease is less impressive. The disease is not so severe as without this drug, especially in a high-risk population, such as those with the median age of 80 years. This is important. Another point we saw during the first wave of pandemic was the thrombosis, you know. Actually, when I started to do the study, my perception was that since some patients were referred at the beginning with thrombosis, I reasoned, but what could happen in a patient who is constitutively prone to thrombosis because they have MPN, they have AT, PV, or myelofibrosis. This was the reason why I started to do that, not for assessing the mortality. This was a new things, unexpected, surprised, the mortality was so high. Another point that surprised me is the mortality due to thrombosis. First, thrombosis appears, but not so relevant in terms of frequency. And particularly, we have seen thrombosis, like in the normal population, non-MPN population, in the venous district, 70%, but where in ET, not in PV, MF or pre-PMF, you see 4%, 3%, exactly what you see in the normal population. On the contrary, when a patient with ET got COVID, in these patients, the probability to have a venous thrombosis, especially than arterial thrombosis, was particularly elevated. And thrombosis occurred in the first 4 days after hospitalization, very early complication, contrary to PV and MF. And this is the cumulative incidence over time. You start here with thrombosis in ET, and you reach the plateau after 1 month. So means that you start very soon, but you accumulate venous thrombosis or arterial thrombosis over a period of at least 1 month. And this was particularly frequent in ET, as you see here. In ET, 17% was affected by this complication versus 5%. And the curve here was steep, very steep, rapid steepness, starting from the first hour after hospitalization. What to do that? There are many clinical trials going on here to avoid this by giving drugs against platelets, not only aspirin, but also other antiplatelet drugs, such as clopidogrel, ticagrelor, prasugrel, and so on. But it is unclear whether this drug can actually reduce the risk, but don't have any information about this in MPN. We don't have this information. What we have is this. The American Society of Hematology recommend not to use high-dose heparin to reduce thrombosis. Otherwise, you enhance the risk of bleeding. You have to use the normal prophylactic drug for heparin that is not so high as in the patients who need to be treated because they have actually a thrombosis in the legs or pulmonary embolism. You shouldn't use high dose as a prophylaxis. Prophylaxis means to avoid the occurrence of the first episode. Therapy means when you have the episode, then you have to enhance the dose of heparin. Can you follow me? Can you follow me easily? Or should I modify? Should I modify something? Is okay?
I think it's very good. It's
Very
okay.
good. Thank you. I go on then. So, as I said, careful for bleeding. So the use of antiplatelet drugs, the use of heparin should be weighed against the risk of bleeding. And in these diseases, the bleeding corresponds to 4% of the patient. It's not zero. The bleeding could be gastrointestinal, muscle bleeding, some cases of hemoptysis, and in some patients, you need transfusions, blood transfusion, where particularly in myelofibrosis. And it's clear because in myelofibrosis is much more easy to have a low platelet number, and you need sometimes platelet transfusion here, but also red cell transfusion because severe anemia. So for thrombosis, ET is much more exposed. For bleeding, MF is more exposed. So careful in using heparin here in myelofibrosis. We followed the 125 patients surviving, and we have seen after 60 days, after 2 months, that the initial disturbances fortunately disappeared. No more fever. Cough was only registered in 3% of patients. Dyspnea remains, so difficulties of respiration in 10% of these patients, and fatigue also in 20% of these patients. But the other disturbances were no longer registered during the post-COVID. However, what was important is that some patients, after some months, at the end, when they were discharged, they can develop thrombosis as well. So that, careful for that, for giving in these patients that could be considered at high risk for thrombosis, you have to do a prophylaxis for that. Another point that was very, very much important is that sometimes in 3 patients, we have seen evolution of the disease, evolution of MPN. You know that patients with MPN, they can have 2 phases. The first phase is associated with a stable disease, chronic disease. But in the subsequent phases, can evolve towards overt myelofibrosis, for instance, if you have ET or PV, or you can evolve towards acute leukemia. We observed that 3 of these patients evolved towards acute leukemia. And before COVID, they still had a chronic phase of the disease. And there is an explanation of that, because some genetic lesions in these cases were present also before COVID. And when you have a COVID, you have some problems that can exacerbate the disease evolution. And this is due to inflammation. During COVID, if you do biomarkers of inflammation, you will find very elevated, for instance, PCR, protein C reactive. You can see the neutrophil lymphocyte ratio is particularly elevated. These are biomarkers of inflammation. And inflammation can be deleterious for a long exposure in some patients having already some propensity for previous genetic lesions. They can produce an anticipation of what could be the destiny of this. After months or year, you get this in a few months after this high-grade inflammation exposure. At the end, you see here, after the first wave, 9% of this patient continue to die, so that the mortality, if you consider 28% during the month in the hospital, you have another 9% to add to this population, so that the mortality is higher than 28%. It becomes 35%, unfortunately. And these are all the events that can experience patients after discharge from the hospital. 60% are free of problems. So the first wave of COVID was terrible, causing mortality, and for those who survived after the acute phase, still continue to have some problems here. First wave, okay. What happened in the second wave? Second wave, I remind you, second wave was not in the period, in this period. The period was from June 2020 to June 21. This period, in this period, we collected in Europe 304 patients. And we describe exactly what happened here. And we compare all the complications seen in the second wave with those seen in the first wave. And as I said before, in the second wave, the concentration was not so high as in the first wave. It was diluted over a period of 12 months, not in 3 months, 12 months. And differences from the two waves are here presented. First, more males. Second, in the first wave, females were 42%. In the second wave, 52%, 10% more. You remember, maybe you don't remind the fact that at the beginning they said, this is a disease that affects mainly male gender than female gender during the first. Subsequently, more females. And what is important, the second wave in red, less elderly patients, only 34%, but more younger patients, more younger, 40% versus 24%. So females, younger patients. And what about the type of PV, ET, myelofibrosis? There was no difference with one exception, myelofibrosis. Less myelofibrosis here. The reason is that because there was the awareness that patients with myelofibrosis, major care should be more protected than the other, because we had the previous explanation of the high mortality, so that major care for patients with myelofibrosis. And another point that should be considered, look here, less ruxolitinib. So they were less treated with a drug that can have, especially when you suspend, when you discontinue this drug, is associated with bad outcomes, as you know. So difference, younger, less myelofibrosis, more females, less treated with ruxolitinib. And another point is that while in the first wave, patients were admitted to hospital in about 80% of them, in this case, were admitted in the hospital only in 20% of patients. They were followed at home. Why? Because the disease was less severe. And the respiratory need was lower. The O2 saturation, the oxygen saturation was better, and the symptoms, fever, cough, and dyspnea in the second wave were less present than in the first wave. So the disease was less severe. And another point important, as I told you, is the inflammatory marker. That is important, the inflammation. The inflammatory marker seen as a neutrophil to lymphocyte ratio was lower here, and the C-reactive protein, that is another marker of inflammation, was lower in the second wave, so that these patients were a lower risk as compared with the first wave of the pandemic in the second wave. And these differences were different also for some drugs directed for COVID disease, not for MPN, for COVID disease. For instance, the use of antibiotics, antithrombotics, and other experimental therapies. But if this could be the case for patients treated with ruxolitinib, you see here, in the first wave, 24% of the patients were, when they got COVID, on treatment with the ruxolitinib. In the second wave, only 9% of patients. So doctors were more reluctant to prescribe ruxolitinib in the first, in the second wave as compared with the first wave. All this data may produce this curve. If this is the mortality of the first wave, this is the rate of mortality of the second wave, meaning that the mortality was here in the second wave only 8%, 8% versus almost 30% here in the first wave. And if you do the multivariable analysis to see which were the factors that independently from the others were responsible for that, you realize that age over 70 was terrible, unfortunately. 5 times higher mortality also. Important the need of respiratory support, and still the discontinuation of ruxolitinib remains a factor that enhances the mortality rate. But this is valid for all the classes of age, but one. And the one which did not benefit of this improvement of mortality was those over 70 years. You reduce the mortality also in the from 36% to 21%, but not the same extent mortality reduction that you can find when patients are between 60 to 70, the majority. You see here, before you had 35%, in the second subsequent wave, only 2% of mortality. So good for all ages less than this age, over 70. Over 70, you reduce, but you still have an excess of mortality. And the phenotype was first, unfortunately, MF, still 60% of deaths were myelofibrosis, 20% of ET, and 18% of PV. And these are the patients. I'm too long. So the mortality, and this is the thrombosis. We have also an improvement of thrombosis in the second wave as compared with the first wave. The event-free survival was better also for those patients that were discharged from the hospital. So we concluded that the mortality significantly decreased during the second wave. Inflammation was decreased. Ruxolitinib discontinuation was decreased. And we now are facing with new problems here that are the problems of Delta or Omicron variants, and this study is ongoing. But I have to say that this is a variant of concern because the very aggressiveness of the disease, 3-fold greater than before, And the Omicron also, notice that Omicron appeared for the first time in low vaccinated young patients in South Africa. The last point I want to say is vaccination, but I would prefer questions about vaccination. I will answer some questions by presenting some slides if necessary. Thank you for listening to me.
Thank you very much, Professor Barbui. That was a very interesting presentation and very important for these patients to know this information. We have some questions in the chat. Maybe we can start with them.
Yes.
One question is if you would be considered to be in a higher risk group for COVID if you have polycythemia vera and chronic lymphocytic lymphopenia at the same time and have had your spleen removed. Would you be considered a risk group?
This is a very, yes, this is a very difficult situation because you have a very advanced problem of immunity. The immunity is very compromised in a patient like you. You know that the immunity is compromised in all patients with MPN. Immunity is compromised in all patients with chronic lymphocytic leukemia. Immunity is very, very much compromised in patients splenectomized for these reasons. So that I hope you are well now, but the problem is, did you get a vaccination?
I don't think we have that information from this person.
This is important because, you know, vaccination works if the immune system is good. So, for instance, the formation of neutralizing antibodies against the spike protein, against the virus, say the COVID virus, is not so high. The production is not so high if you are on treatment with ruxolitinib, because as I said, this is an anti-inflammatory drug. An anti-inflammatory drug means you reduce the immunity. So that you need 3 shots. You need the booster. But if you are a patient survived after a COVID and you have been vaccinated with 3 doses of vaccines, independently whether the third was similar to the second or was different, you are lucky. You are lucky because your antibodies, neutralizing antibodies, are very, very high after the third vaccination. I have a slide showing that. This is a very important to know. So the case, the particular case should be treated with great caution, I think. But I think you have a good doctor and he can choose for you what to do.
Thank you for the answer. We don't have much time now, but I was thinking that we can just take one more question, and that is if it's okay to show this information and figures to share this with their doctors too.
Yes, yes.
Okay.
You can write also to me if you have problems. You have my email address. You can do that.
Yes, maybe
Don't worry about that.
I can send you the.
Ask me reasonable things. I'm not Jesus Christ, you know, as I said. Okay.
Yes, but maybe I can send you the questions and we can publish the information on our website so we can answer them at least.
Okay.
Yeah. I have to admit, I'm so impressed because I've heard you a couple of times before, but every time there is so much new information. So I'm so delighted and impressed every time, and so excellent.
Yes. I have to say, Lisa, that I have a new information. We are studying now who needs to be hospitalized as soon as a patient with the PV, ET, or MF is positive, is found COVID positive. Can I predict whether it's better to stay at home or better to go to the hospital? This is the question. It's interesting to know.
Yeah,
because
really.
you do what in medical terms we call triage. We send a patient to the hospital, or no, you can stay at home. Why is important this? Because we can select patients at the very beginning of the infection. It means the virus replicates as soon as enter your body, replicates. But if you have some tests indicating that, listen, the replication is very high, in this patient, you can use antiviral drugs because you don't know whether all patients should be treated with antiviral drugs. So we offer the possibility to select high-risk patients for hospitalization and for severe outcomes during hospitalization. We are finishing this. We will present this data during the European Hematology Association meeting that will be held next June this year. So next time I will present this data for you.
We look forward to that.
Okay.
Really.
Okay.
Yeah. So interesting.
We have to win the battle.
Yeah, of course. That's important.
Yes.
Yeah. And just to let you know, we got so many thank you notes in the message right now.
Oh,
so,
good,
yeah,
good.
Yeah.
Good.
Yeah.
Good,
Yeah.
good. I am very happy to know that you are interested also in participating in the board for clinical trials. This is extraordinarily important to have patients in the board. I have to say that in the next few weeks, we will have a meeting to know how to do that for you, for patients, how to do that. Because the methodology for including patients at the beginning in constructing clinical trials is not so easy. Who should? What could be the level? Why? And so on, many questions. But this is relevant question. Just to answer the question you raised before when you said unmet needs. The unmet needs are revealed by the patient, sometimes by the doctors, but mainly from the patient. What is the main unmet need for you? Maybe different from that on another patient. So at the end, we have to decide what is first, what comes second, and so on. Interesting, very interesting.
Really.